Okay, good morning everybody. So today we are going to be discussing about aspects of history taking in children. I believe you had a session on history taking done by the medicine faculty, and we are going to discuss aspects which are specific to children, and also re-emphasizing some of the points that may have been discussed yesterday. So let's first kind of try and understand what's the purpose of history taking. When we are taking a history, we are talking to the parents and to the child as and when it's feasible. The main purpose is to know about the complaints, concerns of the parents, concerns of the child. Try and get a narrative which could explain the symptoms, and we could get to a set of differential diagnosis which we would work on further and try and get some confirmatory findings on examination, and based on that we could have a composite evaluation to decide about further any investigations are required or not. Interestingly, about 70 to 80% of the pediatric diagnosis in an outpatient setting can be made mainly on the history. A lot of these may be minor complaints like upper respiratory tract infections. There may be sore throats. We are dealing with children with acute illnesses like diarrhea. And even when we are looking at other histories, other chronic conditions, be it seizure disorder, be it conditions like nephrotic syndrome, we could be working on that as well. So the purpose is essentially to look at a detailed account which is going to come from the parents and work in a systematic manner. When we are taking a history, it's not just a translation of what the parents or the family or the child would have told us. It's an intelligent workup that would have to be done, starting with what the presenting complaints are, and based on that we would start further and ask specific questions. But it's very important for us to allow the parents and the child to talk rather than immediately kind of putting up multiple questions. So let's see what are the different approaches to arrive at a diagnosis. So we have, this is just a kind of a representative case. So this is a 12-month-old boy who presents with a history of fever of 39 degrees centigrade, which was measured by the parents for a day. Child has been having upper respiratory symptoms, a bit of runny nose, mild cough, and for 2 days, and the child had multiple crying episodes at night. Other than that, there were no significant history in the past. Child had been well thriving, feeding well, had been immunized for age. And on examination, the child appears to be a bit fussy, but is consolable. Not too interested in surroundings, but keenly watches you as you move around while you are examining. And the physical examination is normal. Overall respiratory status is good. There's no evidence of any distress, no fast breathing, no chest indrawing. The hemodynamic status is good, no tachycardia, peripheral perfusion is good. And at time of examination, the child is not febrile. Now, what would be our possibilities in this kind of a setting? So what are the things that we are looking at? So we're looking at a high-grade history of high-grade fever, and things which we would be worried about is whether we are dealing with any serious infection or serious condition. In this kind of a setting with upper respiratory symptoms being present for 2 days, the child appearing a little bit sick but still is aware of the surroundings, it's watching you. Physical examination not revealing any significant impact on the respiratory or the cardiovascular system, your main possibility still is going to be viral infections. But in infants, we know that there could be serious infections which may be troublesome, and particularly worrying in this setting would be child having multiple crying episodes at night, which may happen with conditions which are as innocuous as nose block, just the nasal passage getting obstructed due to secretions, to something like meningitis, where the child may be excessively irritable, and that's what would be causing trouble. So how do we go further? So we can see that whenever we are dealing with a situation, it's not that it's always going to be 100% certain that this is the possibility, and one is constantly working with probabilities. Probabilities are, you're looking at what's the possibility of having a particular condition, what are the other possible diagnoses, and what could their probabilities be. It's just, you could say, what is the chance of having a condition. So in this child, let's say if we are looking at fever, respiratory tract symptoms, we would say the most likely diagnosis is going to be upper respiratory tract infection, which is of viral etiology. The other possibilities you would consider are serious infections like meningitis, or it could be a urinary tract infection, though you can't explain the upper respiratory symptoms based on that. Now, when we are trying to work through history, examination, and we do investigations, the main thing that we are trying to do is we are trying to improve upon these probabilities that come to us, or the possibilities that come to our mind, and depending on what kind of probabilities or with what certainty we have a diagnosis, we would be going ahead and starting to treat the patients. So as an example, in a child like this, if we have the suggestion of a viral respiratory infection, and let's say it wasn't the current times like COVID, here if the COVID pandemic is on, this easily could be COVID disease, and in which setting you would have to confirm with a respiratory specimen subjected to RT-PCR or antigen detection to say whether it is COVID or not. It may not have any treatment implications, except that if the child is diagnosed to be positive, you need to take precautions of isolation, protection of the family members, and so on. But let's say the same condition was happening a year prior, let's say hopefully a year later. In that setting, we would have just given it a label of viral upper respiratory tract infection. There's no specific treatments for most of the viral infections which cause URIs. And all we would have done is we would have done symptomatic care, take care of the fever, hydration, feeding, and explain the parents signs of any worsening. It could be fast breathing, it could be difficulty breathing, respiratory distress, chest and drawing happening, or the child become excessively irritable or excessively lethargic, activity getting reduced, or intakes reducing. So these would be the issues that you would have to explain them. So here we may not need to do any investigations. You don't really go around doing samples of the respiratory specimen for finding out which virus is it, because it probably doesn't have any impact on how we are going to manage, except the current situation which I mentioned, that in setting of COVID, even though we may not have specific treatment for a mild infection, we wouldn't want to treat apart from just symptomatic care. We would need to work with apart from that, we would work with just a clinical diagnosis. On the other hand, there could be a scenario where a child comes in with a lump in the neck for 4 months duration, which has been gradually been increasing. It's painless, there is no markers of inflammation, no erythema, no tenderness. In this kind of a setting, one may work with possibilities of chronic infections like tuberculosis, or on the other extreme, it could be a malignancy, it could be a lymphoma. Now, in this setting, even though clinically we may be reasonably be certain that it's, let's say, if we have other features and we strongly think that this is likely to be a lymphoma, we would never start treatment empirically. We would always want a lab confirmation, and therefore, when we're talking about medicine and we're talking about uncertainty, we're always kind of weighing the pros and cons of going ahead with a particular strategy of investigating the information that we're going to get, and how we are going to use that information, be it for diagnosis or for management or for prognostication. So all along, what we are going to do is we are going to be working with probabilities in a certain manner. We may not explicitly say that as a number. There would be, as we go further and we learn more about evidence-based medicine, we learn about biostatistics, we would learn how we are going to translate what we think as possibilities into some kind of numbers which makes it more firm, and with which we could also see how we could improve this possibility of a diagnosis. So what are the various strategies to arrive at a diagnosis, and we'll just quickly look at what are the pros and cons of each of these. So one is what we expect, when we all as medical students, we are expected to know about history taking and examination. We do a detailed history and examination. Based on that, we have a set of differential diagnosis. We would have and thereafter plan investigations, and we may manage. And investigations, as I said, are not always mandatory. Very often we would not go and do any investigations, and straight away, based on our diagnosis, on basis of history and examination, we're going to start the management. Now, what are the advantages in this kind of a setting? So in this, even though we may not have read about each and every disease, by a systematic approach to history taking, we could still get down to, or shortlist a few conditions as differential diagnosis. So typically, let's say the clinical postings start when you're studying pathology, microbiology, pharmacology, and so on. Obviously, when you first start, we all do not have idea about all the conditions that we're going to encounter. So if we go through this systematic approach of history taking examination, I think we can still get down to at least try and narrow down the diagnosis. We may be able to say what organ systems involved, within that system which particular specific organ or parts of organ are involved, and what may be the likely etiology, whether it's acute infection, chronic infection, whether it's a malignant disorder or an autoimmune condition. So we may still be able to get down to that much. On the other hand, if we had to go the other way around and say that, okay, we should have read all the disease conditions and only then we are going to be able to diagnose patients, that's a pretty laborious and a difficult proposition. Wouldn't really happen in that way. The cons are that it's time consuming. You would have to, the certainty with which you can get to diagnosis may be a bit lower, and it's dependent on the person who's taking the history, how diligently the history has been taken. And as you would see, at least you would have had some exposure to the clinics before the lockdown and all happened. You would see that when a student, or when we are just beginning as medical students, we would take half an hour even for a OPD case to be looked at, taking all the details. On the other hand, the person or a resident or a faculty who's managing the OPD would often spend not more than 5 minutes for a particular case scenario and be able to come at a possible set of differential diagnosis and plan the investigations and start the management. And this difference is essentially coming in with experience. In the setting that the history taking becomes a little bit more targeted, focused, starting with the primary complaints. So therefore, we need to make sure that as we go through the process, we spend enough time in history taking with the idea that we need to get to a possible diagnosis. It shouldn't just become a template kind of a history that you're doing, asking certain set of questions for each and every patient. That approach may be fine to begin with, but over a period of time, we need to refine that and make it more focused history taking. Only then it's going to be time efficient. The other approach which people at times take is have a panel of investigation. So you could have a child who's come in with fever for one day, just as we had this child. Now, instead of really focusing too much on history and examination, it's possible that the doctor may actually order a battery of investigation. They may say you do a complete blood count, do a ESR, do a C-reactive protein, get a chest X-ray done, get a blood culture done, get a urine examination done, and so on. And that would be a panel which would be kind of given at a go rather than any targeted kind of investigations. Now, the pros may be that you are trying to have definitive diagnosis based on lab criteria for a number of conditions which may be prevalent at that time point, and one would need to be aware about those. The cons or the negatives are essentially that this is a fairly cost-intensive strategy. So obviously, it's going to cost a lot of money. Even if it happened in a government setup, the government or the institution would have to pay. At the same time, the child has to undergo blood sampling, would have to go other investigations. So that's the flip side. So if we go with this approach, most people would believe that this is not a very rational approach, simply because it may be for the reasons that I just mentioned. And it would be better to have investigations which have been guided by the set of differentials that we have based on history and examination, rather than blindly doing it based on one presenting or two presenting complaints, planning it out. Now there could be some other methods of diagnosis as well. So these are what are known as based on your observation skills. They would be based on experience over a period of time, and one would look at a particular individual, and just by inspection or just by observation one may have a set or a particular differential diagnosis. This is what we call as kind of a pattern recognition, and this would be applicable to a large number of skin disorders where the rashes may have a particular characteristic, though the characteristics at times may be non-specific. And it would also be applicable to, let's say, genetic syndromes like Down syndrome, where a child with tanners is what one may easily be looking at. One scenario, look at the morphology, and look at whether it could fit in with a diagnosis. Now the only issue with this kind of an approach is that even though it is fast, you may look at a person and be able to make a diagnosis, but the problem is that this again is based on experience. You would have to have had at least some experience in looking at such kind of scenarios previously, so it's kind of determined by your knowledge about this kind of a condition prior to when you have actually encountered an individual. So these are some of the methods that we could be using, and very often we use a combination of these methods to arrive at a diagnosis. The role of investigations again has to be titrated, because investigations can be expensive and we should do them only when they are essential. At the same time, we need to have this realization that there's hardly any investigation which is entirely foolproof. You must have heard about terms called sensitivity, specificity, and these are basically telling us for sensitivity that how good is a test to really pick up an individual with a disease or a condition. So let's say a test which has a 90% sensitivity would mean that if there were 100 individuals with that condition and we ran a test, it would be able to correctly identify 90 of those, but it's going to miss 10. On the other hand, specificity is more about ability of the test to correctly identify an individual without the condition. So let's again say we have a test with a specificity of 95%. What it essentially would mean is that if there were 100 individuals without a particular condition, even though they may have had suspicion of that condition but actually do not have that condition, the test is correctly going to identify 95 of those, and the 5 are going to be falsely be labeled as having the disease, whereas they don't have the disease. So I think some of these may be better explained when we have small group sessions in terms of how one would be using these modalities to modify or fine tune or refine our diagnosis. Now the framework of pediatric history taking is broadly the same as would be done for adults, and you had a session with Dr. Anveer about how the history taking is done. So I would try not to repeat what has already been talked about, except for some overlaps. So one of the key things is that what are the key differences as compared to the adults when we do talk about the pediatric history taking. So obviously the first major component is the informant. So if we have an infant or even a young child, or maybe children who may be up to 10 years old also, most of the history components is going to be given by the parent or the guardian, and therefore it would be more about their perceptions about the child's illness or symptoms than what the child actually may be going through. Now very often and if you have to give weightage to this information, we need to have some idea about how reliable this particular history is, or whether what they're telling is actually valid or not. So it's always important to spend some time on this assessment as to who is giving the history. So, and how would we figure it out? So one of the key things is to really find out whether whoever is the caregiver is actually staying with the child regularly or not. And that's something that's going to be important. So very often we would have children who are brought in from distant parts of the country, and it may be either a relative who's accompanying the child who's been told the history by the parents, and that person is actually not staying with the child. It could often be for a young child, an infant or so, it's the father who's brought the child to a facility and not the mother. Whereas if you actually look at it, the mother would be spending almost the entire day with the child, whereas the father may not be able to do so because of whatever reasons, be it the place that he works or the working hours that may be there. A similar thing may be happening for women who would be working, and maybe it's another family member who's actually looking after the child through the day, who may be able to give a more detailed account of the child's symptomatology than, let's say, either of the parents. Now, that would be one of the components. The other is about how well they are able to tell. So as we said, that the parents are only telling their perceptions about the child's illness. So we have to have some kind of a measure about whether they are giving a coherent account. For short histories, it may not be a big issue, but let's say if there's an illness which is lasting 6 months' time, we need to know the sequence, which has to be a correct sequence of different symptomatology. So it would be something like, if a child had fever for 6 months duration, had abdominal distension for 4 months duration, developed jaundice 15 days back. When we say reliability, it's about repeatability. So it doesn't mean that we're going to ask the same set of questions again and again, that when did the fever happen, when the abdominal distension happened, when did the jaundice start happening. One would have to rather ask that, okay, how many months after onset of fever did the jaundice began or the abdominal distension began? And with different ways of asking, maybe we should be getting around the same information. There may be minor deviations, but there shouldn't be any major conflicts that are happening. Validity is about how true is the account, or how close to truth is the account. Now this is something which is difficult because we don't have a comparator. The only thing which may be available to you is some medical records that may be there, and which may tell us about whether what the narrative is correct or not. So if, let's say, the history is 6 months duration of fever, and let's say there was a consultation sought about 3 months back, then that particular doctor's note should optimally mention the duration of fever at that time as 3 months. On the other hand, if it is 4 months or 5 months, they're really going to be worried about what the actual duration of the symptomatology is. So this is something that we are going to definitely ask before we start the history taking, to get an idea about what who the informant is, what the likely reliability is, and while we're taking the history, we would get an additional idea about reliability and validity. The additional components which have to be looked at are the birth details and antenatal details. This is particularly important for children less than 1 year of age. It's important for children where we are suspecting incidents, perinatal events like birth asphyxia or injuries. That's where it would be critical. At the same time, it would also be important when we are dealing with a possible malformation or genetic syndromes. Some of these details would be important. Family history for the same reason. So there could be different scenarios. We could be dealing with inherited conditions, conditions that run in families. There may be history of a sibling having a similar disorder, which may be either, again, and if the parents are normal, then one may worry about a recessive disorder. At the same time, we also are worried about, it's not just about inherited disorders, it's also reflective of the environment and maybe some infectious diseases which may be there. So common examples, again, innocuous conditions like upper respiratory infection. So very often a family member would have had similar symptomatology, or a sibling may have had a similar symptomatology either concurrently or prior to this child developing, and that may give us some clues. At the same time, conditions like tuberculosis, it's important to ask because very often for children who are particularly young children, and if we are suspecting tuberculosis, it's important to know whether any of the family members had recently developed symptomatology which is suggestive of TB or had a definitive TB. So it's not just the just the inherited conditions, but also infectious conditions. At the same time, there may be certain non-communicable diseases. So let's say if you're looking at obesity, so there may be some genetic component, but it may essentially be related with the lifestyle, which may be more for the family. So the kind of food that they eat, the food habits that they have, the exercise activities that they have. So there again, it would be important. Now, immunization history is something which is very important, and we need to have details. So it's not just about whether the child has a disease which could have been prevented if the child had got a vaccine. So it could be, so conditions would be something like diphtheria, where a child who's not been vaccinated properly may get diphtheria, or tetanus for that matter, or pertussis. But it's also important to know for whatever. So if, let's say, this 1-year-old child came to us, we may not think that this is any of the vaccine preventable diseases, but the contact with the health personnel gives us an opportunity to identify if the child has missed any of the vaccines, and also try and understand the reasons if the child has missed the vaccines, because this gives us an opportunity for a healthcare professional to talk and convince the parents about the need for immunization, and also allay the anxieties or the myths that they may be harboring. Development is again a key component, and this again is true for younger children, where we need to take a lot of this development history in detail. For an older child, let's say a 12-year-old came with the history which is similar to what we discussed, just one-day fever and some respiratory symptoms, the development per se may not be very important to deal with the current condition. In this setting, a quick overview about whether the child's going to school and whether the class that he's studying in is appropriate for his age, and whether there are any learning issues is what we could ask. We may not be very interested in knowing exactly when the child started holding neck, or when the child had a social smile, or started turning from supine to a prone position, or sitting up, or started standing without support, and so on. Whereas if this same child had come in with a 12-year-old coming in with seizures, one would definitely be interested in more detailed account of what the development history would be. Similarly, nutritional history is something which would be very important for all age groups, and it would be important to really figure out what's the intake, what kind of food habits the child has, the family has, and whether that needs a correction. Again, this is very important for a situation where we may have a malnourished child, and there it becomes critical to have an idea about what the nutritional status is. Now, it's very important, and yesterday in the session from the medicine department, I think there was a component which was discussed was the doctor-patient relationship. And here, even though we may be talking to the parent and the child is just an observant, we need to make sure that we conduct ourselves well. We get into, if we get into a good rapport with the parents, would the child allow us to examine when we get down to examination? If we are not very gentle, if we are pretty loud and aggressive when we are taking history, we're not allowing the parents to speak, then the probability of eliciting cooperation of the child would definitely be much lower. And as compared to adults, in a usual setting, it's much more difficult to examine a child, and the process of examination or observation begins the moment the child and either the parent or the guardian kind of walks in. You start your observation, and it's very important to have careful listening to the parent or the mother. And it's very reasonably well known that a smart mother makes often a better diagnosis than a poor doctor, because she may be knowing what is wrong with the child. She may not be able to correlate what exactly is the cause, but at least she'll be able to have a good account of what the child is going through. So it's important to establish rapport with the mother, get into habit of quoting verbatim from the mother. You may have some modifications or editing of the narrative that you get. And it's important to, this is something which often we end up saying, that if only I had listened to that mother, she was trying to tell me what was wrong. But in our over enthusiasm, very often we start shooting questions, and we may be a bit biased towards a particular diagnosis, and we focus all our attention to get to that diagnosis even if it's not there. This is again a famous saying that you need to listen to the patient. He is telling you the diagnosis. So here it would be listening to the parent or the mother, because he or she is going to be telling us about or lead us to the diagnosis. Now, when we come to the demographics, again we need to ask about the name of the child, and whenever we are taking history, it's good to ask about how, let's say, that particular child has been doing, rather than just being non-personal. It's important to know about the age specifically. Now, in adults, we are generally good with saying the patient telling that, okay, I'm 30 years old or 35 years old. It may not make much of a difference whether the person is actually 30 years old or 30 years and 9 months or 31 years for that matter, because that may not be very relevant in terms of the differentials that we may be thinking about, or it may not also be relevant about the diagnosis or how we are going to manage that child or how we're going to evaluate. On the other hand, in a child, it's critical. So a 1-year-old is not the same as a 10-month-old or a child who is 18 months old. We need to get down to the exact age. And the only way to do that is to try and figure out what the date of birth is and actually calculate. And these days, most people would be carrying immunization cards, or they may be carrying Aadhaar cards or some form of identification with which we can know. If not, then one would still try and get to the best possible idea about the age by asking the parents about the month of birth and the likely year, the year that they know. Now, it's important to get an idea because very often, let's say in this part of the country, very often the parents are going to tell about the running year. So the moment a child completes, let's say 2 years of age, they would say, कितना उम्र है बच्चे का, तो कहेंगे कि तीसरे में चला गया है या 3 साल बोल. Now what essentially they are trying to tell you is that the child got into the 3rd year of life, but the way they may say it or way we interpret it, we may assume that this is a 3-year-old child. Now the problem with this assumption is that when we are doing our evaluations, whether the development is appropriate or the nutrition is appropriate, we are going to be off the mark, because we may find that the child appears to be having some developmental delay, or the child has some malnutrition, whereas actually the child doesn't have either of these. On the other hand, if the child is, the age is told to be lower than what that actual age is, we again are going to be wrong about some of these evaluations about the development and the growth. So we need to be carefully looking at the date of birth and where the actually parents reside, the usual area of residence. Now very often people would come from different states, and in that kind of a setting, they may have come to a relative who is in Delhi, and they would give the address of Delhi. Now we are likely to miss out on certain endemic diseases which may be prevalent in certain areas if we didn't know about the place of residence. So it's always important to ask where the child is actually staying, or for a school going child, it may be important to know where actually the child is schooling, rather than just looking at the card and saying, okay, this is the current address. Then we need a narrative of the presenting complaints. These are what the caregiver, parent or guardian would tell us. We need to have it in a chronological sequence. One may start with the most recent complaint, like in the case that we discussed, highlighted, fever for a day, upper respiratory symptoms, cough or coryza for 2 days, and so on. And this would essentially be coming from the parents or the child. We are not really intervening in this in the sequence and so on. We are not asking any leading questions at this time point. Then we move on to what are the history of present illness or history of present complaints. And the main purpose here is to try and localize the organ system or the organ which may be affected. Try and look at what the possible etiology is. And also if we get down to a disease or a condition, then we're trying to know about what the extent of that disease or condition is, or how severe it is. And this is how we are going to be looking at the overall framework of history taking, and that's kind of common to whether you're dealing with a child or whether you're dealing with an adult or whatever condition. Now within this, we are going to be asking about the typical is to really find out or ask from the parent is that till when the child was doing fine. And we may have different kind of scenarios. So we may have a child who comes in only with an acute illness and has been well previously. There could be another scenario where the child has some underlying disease. So let's say a child may be having a developmental delay or a seizure disorder or a nephrotic syndrome. So we may have to say that okay, we are dealing with a child who has a known or a diagnosed case of nephrotic syndrome, and he has currently come up with upper respiratory symptoms. And that would be it. We wouldn't really give too many details of the nephrotic syndrome diagnosis and condition here in the present complaint, and that's going to go to the past history. On the other hand, we could have a child who has developmental delay, which kind of began with the history wise. The child had birth asphyxia, had early onset seizures, and so on. Now, this is, if the child is presenting to you with seizures, then it would be relevant to start right from the birth. So, your history of present illness is going to start from birth in this kind of setting. So, we need to decide about this on a case to case basis rather having a uniform framework. So, there could be, as we said, there could be an acute illness, there could be a underlying illness, and the current symptoms are unrelated to that underlying illness. And there could be a third scenario where the child has an underlying illness and the current symptomatology is actually a flare up of or worsening or a recurrence of the underlying condition. So there would be different kind of starts to the history as to, in a usual scenario, one may just say that the child was well till 2 days back when he or she developed so and so. On the other hand, there could be another scenario: the child has nephrotic syndrome and now he's come with acute respiratory symptoms. So that would be one. You're not really going to give details of how the nephrotic syndrome was diagnosed in the history of present illness. On the other hand, a child who comes to you with acute seizures, has an underlying developmental delay and seizures previously, you're going to have to start right from that history of birth and then go further and come down to what the current condition is. Now, we are going to first of all elaborate upon each of the presenting complaints. And so here, let's say we're talking about fever, so we're going to have to tell about the degree of fever. Very often the parents just have a subjective impression of fever, they don't actually measure the temperature. So all of that would have to be told, whether the pattern is discernible, the temperature touches normal or not, what kind of medications have been given and whether that has any effect. So these are things that we're going to ask. Similarly, the child may have history of cough, so we would want to know the character of cough, whether it's dry cough or whether there's a suggestion that it's like a wet cough, something that's secretions in the respiratory passage, the intensity of cough, whether there's any diurnal variation. There could be a possibility that the cough gets worse when the child lies down, and in that setting it may be indicating a post-nasal drip. Whatever the nasal secretions are, they would be getting down into the throat and causing irritation to the mucosa, and which then would be activating the cough mechanism. So this is what we would have to be looking at when we are talking about the presenting complaints. If you have a seizure disorder, we're going to need to know when exactly it began. It's an observed or an unobserved seizure. What was the sequence of events or semiology in a way as to did the child turn unconscious, then the child had stiffening of body and some abnormal movements of the body and so on. So these would be critical, and this information can only be elicited from history, or the only other mechanism would be if you view the child or observe the child when the child actually has that episodic event. Then we are going to get some more details. So if you think that there is a respiratory involvement, we would want to know whether there is any chest pain, difficulty in breathing, any noisy sounds. So just trying to localize where that particular symptom may be, and some of these aspects are going to be discussed in detail when you come down actually for your clinical postings. This is when it's going to be discussed. Then we need to try and figure out whether, what part of the organ system is involved. So let's say if we're saying the respiratory tract is involved, so we can broadly divide it into upper and lower respiratory tract. And there may be certain indicators which may tell us that, okay, the condition is more like a lower respiratory tract involvement, like difficulty in breathing, chest in drawing. There may be, on examination, there may be fast breathing. At times parents are able to tell you how the child has been breathing or is breathing fast or not. And then other examination which may tell us about whether there are any added sounds or auscultation. So these are going to give us clues as to what may be the organ system that's involved. And then we need to have a set of questions which are going to focus on the etiology. So in an acute setting, we really don't have too much to ask for. Most likely if we have another family member affected and so on, we are going to think about a viral infection. On the other hand, there may be other conditions which may be chronic conditions. Fever may be persisting, there is significant drop of appetite, loss of weight, the cough and all, and the child is coughing excessively, which is worsening over a period of time, has weight loss. So one is likely to think about chronic conditions with fever. One may think about chronic infections like tuberculosis. One may also worry about whether one is dealing with any neoplastic conditions. And so one is going to try and work at the end of the present history. One is going to look at what is the likely organ system or part of that system involved, what may be the likely etiologies, and we could prioritize based on what we get on the history. The next component obviously is about looking at history of any past illnesses which may be significant. So a child may be having recurrent upper respiratory tract infection. So children less than 5 years may have up to 8 to 10 episodes per year. So that in itself may not be much. But if, let's say, the child is getting sick every 2 weeks or so, then we need to worry about whether there's any underlying malformation or there's underlying immune deficiency, which would be important. We need to take details of the perinatal history, the mode of delivery, birth weight, any perinatal events, birth asphyxia, delayed cry, seizures, child needing admission into nursery or neonatal ICU. So this is what we are going to be taking in detail about perinatal history. And as we said, for disorders which may be inherited, or there may be congenital malformations or congenital infections, we would also be interested in knowing about the antenatal period of the mother. The treatment history is important, particularly when the symptomatologies are long lasting. So one may not be getting too much when we have 1 day history or 2 day history. The only thing we may get is that the child receives some medications to reduce the fever, like paracetamol or ibuprofen. So we need to know the details, the doses, how frequently these have been given. For chronic conditions, this may be more exhaustive, and one would need to get down to details, whether the child's got particularly anti-tubercular drugs, the kind of doses the child has got, and one may have to refer to the records if the parents are not able to tell exactly what the medication history is. Family history, we have discussed the details that we're going to draw out a family tree, and in subsequent sessions we're going to talk about how a family tree is actually drawn. Depending on what kind of condition we're dealing with, we may draw 2 generations or more. So the minimum that we need is the parents and their children or siblings of the patient who's presented to us. But if you are looking at certain recessive disorders or inherited disorders, we may have to make a family tree which runs into multiple generations to really get an idea about what kind of inheritance may be there. The other aspects are obviously related to development. So a lot of developmental evaluation actually happens on history. The examination may not add very much to it. So a detailed development evaluation needs to be done starting right soon after birth, early months, maybe social smile, neck holding, interest towards sound, turning the neck towards a bell, for example, reaching out for objects, turning from supine to prone position. So one kind of divides these into various components like gross motor, which are like gross body movements. Fine motor is something like trying to hold an object with a pincer grasp, that is with the thumb and the index finger, is what one is looking at. Then apart from the gross motor and fine motor, one is looking at the language skills, one is looking at the social skills, social aspects of the development. So all of these are going to be dealt with in detail about for what is an appropriate development for a particular age, and whether the child deviates from that and what could be the possible reason. Then another very important component is related to growth and development, which is the feeding history or the nutrition history. It's important to know the details. The common method that's used for taking this history is what is called as a 24-hour recall, which means that we ask the parent about whatever a child has taken in the previous 24 hours. Now this gives us an idea. Now the only catch with this is that if one is dealing with a chronic illness, let's say 6 months duration, and within the complaints we also get a history of decreased appetite and decreased food intake, then obviously the 24-hour recall is not going to give us an accurate idea about what the child's intake was when the child appeared to be normal or didn't have the condition. But it's very difficult to get an idea about or details of what a child ate, let's say 15 days back or 20 days back, means what to talk about 6 months. So one does kind of start with a 24-hour recall and then tries to build upon that to get some more history as to what the dietary intake in the usual time was. And this again is an exercise or skills that we need to learn when we have actual clinical postings, as to getting a narrative or history from the parents. An important component of this is, one, we may easily come to know about what the nutritional value of, let's say, milk is. 100 ml of cow's milk, how many calories are there, how much proteins are there, and so on. But when the parents are going to tell you the history, they're not going to tell you that we gave child 100 ml milk. They're going to tell you we gave a glass of milk or a katori which is full of milk. And then the challenge is to really find out whether this glass is a 200 ml glass, or it's a 150 ml glass, or 250 ml glass. That's a challenge. So it's good to just inspect and get an idea about what that actual volume may be. Then there may be other things. So many people actually add a bit of water to milk for various reasons. So one is that during boiling they feel that the solid material should not stick to the base of the vessel, and if that kind of gets overheated, it creates a bad smell. But many a times people may think that undiluted milk maybe the child may not be able to digest. So they would tend to dilute milk in varying combinations. So some people may add, let's say, a glass which may be about 200 ml to a liter of water, and people may go on to the other extreme and dilute milk, taking 2 parts of water and 1 part of milk, or 1 part of water and 1 part of milk. So unless we get down and specifically ask them, we may not be able to elicit that. Now, instead of here, I would just like to bring a particular component that wherever possible, one may avoid direct questioning where the answer may be yes and no, and rather ask in another way where the person is actually going to give you a narrative. So there could be 2 ways of asking this, that about dilution of milk. So if I ask the parents that do they add water to milk, या दूध में पानी डालते हो क्या, so they kind of, it's more like a threatening kind of a question, and they may understand that adding water is not a good thing, and if we tell the doctor may not like it or may scold the parents and so on. On the other hand, if matter of factly you just ask that how much water you add to milk, this kind of gives a impression that okay, most people add water to milk, its only difference is how much they add. So it's less threatening kind of a question, and you're more likely to get a correct account with this question than with the previous one. Then when we going about nutrition, we would have while we may know that 100 grams of wheat has so many calories and so much protein, but that's not what the parents are going to tell you. They're going to tell you that we gave child 1 chapati or half a chapati, size of which may be variable, whether they added ghee to it. So all those finer aspects would have to be learned when we are talking about taking nutritional history or nutritional intake history in a child. The immunization is again something that is critical, because we know that the government runs an immunization program, and there are multiple diseases which can effectively be prevented by vaccination, which is appropriate. And in that setting, one would have to be looking at, so need to ask. Now, the best way to confirm what vaccines a child has got is to look at an immunization card. Very often the parents may not exactly be able to narrate that, okay, the child got DPT vaccine or a polio vaccine or hepatitis B vaccine and so on. They may just vaguely be able to say, okay, whether it was an injection or whether it was oral medication was given. So these aspects have to be handled carefully. So the best way is to ask the parents about the immunization card. If that's not there, then instead of asking that DPT laga tha, polio ki dawai diya tha, it's best to ask, starting from birth, asking them when all the child got vaccinations and what was the mode of administration, so you'll get a rough idea about what the immunization the child has got. Then we need to know about the social or socioeconomic history, and here it would be relevant for the family as to knowing what kind of a house they live in, what's the access to let's say drinking water, whether they have a toilet at home, what the earnings or the income of the parents are, how many family members are there, what kind of a house is it, is a kacha house or a paka house, how many rooms, how many members share that. So all of these are background information, and one would have to try and so I think would have been told about the Kupuswamy scale, which is just an effort to try and segregate into different socioeconomic classes based on the parents' education, occupation and income levels. Now, just as an idea, at the end when you do all this history, at times while you're going to go do a narrative, it's also good to learn how to do a diagrammatic representation. So one may start with the time 0, then try and figure out what may be happening at that time. 5 days back the fast breathing is there, then the child has had multiple episodes of seizures for last 20 days. So one may also be indicating that, okay, at some time point a medication has been Gardenal has been given or antibiotics have been given. This is the duration of loose stools. So in a pictorial, it's going to be very clear as to what the sequence of events are, and this may particularly be useful whenever you're getting histories which are slightly longish duration. There's not much point in trying to draw this for symptomatology which is 1 day and 2 days and there are only couple of presenting complaints. This is another example where again there may be loose stools, there are fever, chest pain, irritability, there was hemoptysis, breathing difficulty and hemoptysis. So one may draw out the timelines either by the date, or typically you on the extreme right you start as the time 0 and on the other side you just delineate what the time is, and on the y-axis you try and put up what the various complaints are and how they are evolved. So something like fever and chest pain, there were multiple episodes. So it's not, if somebody said that fever and chest pain are there for 1 month duration, but actually if we look at carefully at this, these are 3 distinct episodes. The hemoptysis may have happened only for a brief duration, it's not for the entire period. So a diagrammatic summary is likely to be giving us benefit in terms of just a quick glance, and we can get an idea about what the history is like. So whenever one is taking history, one would have to follow these principles. We have discussed about how pediatric history taking is going to be a little bit different. The overall framework remains same. There are a few additional things. The informant is different, and therefore we may have to have a different approach the way we are taking the history. So I think this is where I'll end, and if there are any questions that you have, maybe you could type it out and we could just try and address those.